Good evening, everybody. We are actually in week 4 of rural onboarding, and it's very lovely to have you all here. We've already had 6. This is our 7th webinar. I'm sure we're all getting slightly webinared out, but I must say this week is particularly exciting as we're going to get into some practical skills and taking a little bit of a break with orthopedics this evening. And we are very pleased to welcome Dr. Hendriks, who's one of our real rural family physicians, with 15 years of experience in rural settings from all over, starting in Ceres, Western Cape, was in Zithulele here in the Transkei, where I thought he still was, but apparently he's now in Upington in the Northern Cape and has always been very much involved in the state sector. And he knows what it's like when the system fails and you and your patients have to just do the best with what you can, what you have available. And so this is going to be a very practical demonstration of that. He's also currently working at the University of Stellenbosch on a diploma in rural health, where he's helping to develop and run the clinical skills module. So not only interested in actually how you make do, but also how you teach others to make do. So we're very pleased to have Dr. Hendriks here. He has quite a lot of ground to cover, and so I've given him permission to go way over time if need be, because we're going to be recording it actually in segments. So if you absolutely have to go in an hour and we're not quite finished, don't stress. It's all going to be recorded and be available. But this is such a good opportunity to actually record some of these skills live. So thank you very much, Dr. Hendriks. I'm going to hand over to you.
Thank you, Madeleine. Okay, let me just get my screen share. There we go. Sorry for the weak pun in take a break with orthopedics. I just wanted to start with something slightly icebreakerish. So there we are. Orthopedics is one of the things I really enjoy. I'm a family physician, so I enjoy pretty much everything in medicine, but orthopedics is like the pudding in it. So I've been involved in rural orthopedics, and in places like Zithulele in the Eastern Cape, where the orthopedic services fails you quite often. And that's why initially we prepared something like this, and I've now just streamlined it for rural onboarding. And I think the idea is so that we can do the best primary orthopedics we can in whichever setting we are. So to get going, let's see. How do I page? There we go. So the discussion points is I'm gonna start with sedation and when you reduce a fracture or dislocation, because I think quite often why people don't want to try reductions, or be it a dislocation or a fracture, is because they don't know how to do the sedation. So just 1 or 2 slides on that, then just a slide or 2 on open fractures and what to do. Then the fun stuff, upper limb, lower limb, and the important fractures we see, colles, radial ulnar, dislocations, all the fun and games when you reduce those. And then I'm going to end up with the last slide on orthopedic, the organization of the system and how to advocate and when to advocate for your patient. So just to say the resources, the book I use most, and in preparing this and when I studied, was the Practical Fracture Management by McRae. We just refer to it as the McRae. So it's a very nice book. I can definitely say if you want to have a go. So we use a lot of that, and then a lot of low cunning. So when you kind of with your back against the wall and you try to do the best with what you have available. So some of the ideas and the tricks I learned over the years, I added in there. So I'm going to start with this slide, sedation in orthopedic reduction. And I think it's very important. You must never try reductions with suboptimal analgesia. The patient is going to fight you. The muscles are going to tense up, and you're not going to get the fracture or especially a dislocation back into space, into the right place. So definitely good analgesia. But we've always got the risk that we make the patient too deep and we can run into problems with the airway. So the way is important. In the hospital in Upington, where I currently work, we've got a rule that the resus bed, and we actually made 2 resus beds in the casualty. Those are the beds where we do all these procedures, because then you can sedate as need be, And if things go wrong, oxygen, mask, intubation, heaven forbids, is necessary, then you can immediately convert into that. The WHO is present. I think it's important to not try and do this on your own. You can't do I mean, people can do a good reduction on their own, but it's always better having at least 2 pairs of hands. So get a buddy when you do the reduction. And the with what is on the PowerPoint, I've got my 4 favorite drugs: propofol, morphine, ketamine, and midazolam, and their doses. And I think use these doses when you sedate the patient. The next slide is some scenarios where you can use it, and the doses are there. Note, ketamine can be given IM, IV, per os, even per rectal. I haven't used that yet, but it's in kids actually very effective. And then midazolam IV, preferably, but you can per os, works very well in kids as well. So here's 5 scenarios just to demonstrate your different options, how to use the sedation. If you've got a 38-year-old big rugby player with a shoulder dislocation, you've got a lot of muscles to work with and to fight. And then it's very difficult relocating that arm if you give 50 milligrams of pethidine and you think you're going to pull it back. So my suggestion is to use propofol. It's a conscious sedation dose of 1 milligram per kilogram. Give it IV. Add morphine if you want. To remember that propofol is not analgesic. It's just going to make the patient sleep. Doesn't take away pain. So maybe add a little bit of morphine. But then with the propofol, usually it's an easy reduction. We'll talk about how to reduce the shoulder now. Then another case is a 5-year-old child with a Gartland 2 supracondylar fracture that you want to reduce. I think ketamine, 1 milligram per kilogram IV. I love IV because it works quickly and it's out quickly as well, where intramuscular or per os, they tend to sleep erratically and for a long time. But yeah, so ketamine, and with the option of adding some midazolam. I am very careful in doing polypharmacy with kids, especially if I'm not in a theater with theater conditions. So because you can overdo it very easily. In a casualty setting with kids, I usually just use ketamine and don't add much to it. Third scenario is an 82-year-old lady with a collis fracture that's displaced and she fell an hour ago. So this is a case where 82-year-old, you want to avoid drugs that drop blood pressure. So propofol obviously is still in play, but probably one we want to avoid. Ketamine, great option, but then you've got to add something like midazolam that just takes away the side effects and the hallucinations come with the ketamine. I think blocks is much better, and we'll explain and demonstrate now in a fresh block, a fracture like collis fracture, hematoma block is actually ideal. Or if you're comfortable doing a brachial block, I love a good brachial block in them at midnight because it's so quick and it works so nicely. So those are your options. A 22-year-old male with a Boxer's fracture on the left hand. We'll talk about a Boxer's fracture just now. I'll also show you an X-ray. But it's a case of an ideal to just do an ulnar nerve block. To remember, ulnar nerve is running. It's your funny bone in the elbow. So you can block it at the elbow where the ulnar nerve is running. You can do a hematoma block right at the fracture. You can do a brachial block. You can also go ketamine, more the systemic drugs. And last example, 34-year-old obese female with an ankle fracture dislocation. So it can be open or closed. So in obese patients, if you go with propofol, you are at risk of, especially in casualty setting, in soft tissues more, so you can run into airway problems. So in that case, I would probably just do a good sedation with some ketamine, 0.5 milligram per kilogram, morphine. And if it's an open fracture where you're going to have to do a washout and a scrub, you can even make the ketamine more. So these are 5 examples of just how to use your sedation drugs and what options to use on them. So something to go back to when you're stuck one day in your casualty. Open fractures, I think the most important thing to remember is take this seriously. The first time you see a patient with an open fracture, you can do the most good in the sense that you can actually avoid infection of bone, which is a long, big problem for the patient. So I've got the Gestalt classification there. I'm not going to go into it, but when you refer a patient, obviously, if you know the Gestalt classification, you can very quickly refer the patient, and the orthopod on the other side knows exactly what you're talking of. Do a washout and IV antibiotics. So I've got the IV antibiotics, what the email suggests. I've got also on the slide. But maybe just as a practical suggestion, if you are in your casualty, a patient comes in with an open fracture. Quite often they're in pain, they're not no-paos, they might be alcohol on board, so the gastric contents is still stuck down there. So it's a dangerous time to do a general, taking them to theatre and a good washout. So what we tend to do is I give the patient some form of sedation, ketamine and morphine mostly, and then I do a good washout with the 2 sisters or 3 sisters helping, and a couple of liters through the open fracture. Wash out and debride, put in a suture if it's nice and clean, couple of sutures closing the wound, and I put on the back slab. I take the patient to the ward, they get their antibiotics, and depending on if it was just a Gestalt 1 clean fracture and there was no contamination that I could see on the first washout, usually that's enough. Otherwise, I take them back after 48 hours to theatre where I can do another decent scrub, and then I repeat that as many times as necessary to get the wound nice and clean. So open fractures is to be taken very seriously, and yeah, those are important points, I think.